All right. Is this visible to everybody?
Yes, ma'am, it is.
So this was a 60-year-old female. She came to the OPD and was actually admitted later on. She had squamous cell carcinoma of the lung with metastasis to the contralateral lung and to the brain. Presenting complaints were weakness of the right upper and lower limb since 20 days, with 3 to 4 episodes of sudden jerky movements of the neck. Now, she was diagnosed with metastatic carcinoma of the lung in 2022 itself, in January. She was, however, apparently well till 20 days back, when she developed progressive weakness of the right upper and lower limbs over the next few days. There was no history of a fall or loss of consciousness, and during this period, she had 3 to 4 episodes of jerky movements of the neck, followed by severe pain in the right upper and lower limb. She also gives a history of blurring of vision on and off. Now, on examination, patient was conscious, oriented, ECOG score of PS4, pallor plus, no icterus, cyanosis, clubbing, no edema, vitals were normal, respiratory system. I did mention it, there was metastasis to the contralateral lung also, right? So there was bilateral air entry, but decreased on the right side. CVS was normal, her abdomen soft, non-tender, everything normal there. CNS, higher motor functions were normal. Speech, language was all fine. Cranial nerve examination was also all right, except for 11th cranial nerve, which we could not assess. As far as motor systems involved, the right side power was 0/5 when she came in both the upper limb and the lower limb. And on the left side, it was 5/5. Muscle tone was reduced on the right side, upper and lower limb. Sensory examination was normal. Reflexes were intact. I have not written this because at that time, not examined. Reflexes were intact. Treatment and significant investigation. I don't think I have her reports to share here, but all the blood work was normal. Liver functions, kidney functions were normal. So hemoglobin, TLC, DLC, everything was normal. CECT, I'll just read this out for everybody. So chest, there was a mass in the right hilar location with complete occlusion of the right main bronchus with extension to contralateral lung and brain metastasis. CECT head showed a peripherally enhancing lesion measuring 3.6 centimeter, LAD seen in left frontal lobe with mild perilesional edema. Previous scan in 2020 also showed a ring enhancing lesion. Size was smaller, again with mild surrounding edema. She was advised, I think this is whole brain RT in January, but had refused and then was lost to follow up. She came back only now in May. So the treatment that has been given to her since admission is Dexa was started 4 milligrams 4 times daily for 4 days and then tapered. Syrup glycerol 15 ml TDS, injection Levera 500 milligram BD, tab-acetazolamide 250 milligram OD for 3 days. And meanwhile, she was counseled and she agreed to receive RT. So 4 cycles are over and 1 more she's going to take. She's been discharged, so she will take 1 later. So patient was discharged with a referral to neurology and for 1 more cycle of WBRT. Psychosocial aspect, she's a resident of Bihar, was a housewife, looked after by son and daughter-in-law, doesn't have a husband, her husband's passed away. She's aware of the diagnosis, but somehow as per her daughter-in-law, she says she seems to have forgotten about the disease earlier on. So right now, of course, she's aware that something is wrong with her, but daughter-in-law says that she had forgotten that she had any disease at all. Medications that I've already discussed. So main concern is the motor weakness, which is currently upper limb is still at 0/5 and lower limb there was minimal improvement. It's at 2/5. So summary, she's a 60-year-old female with right carcinoma lung with metastasis to contralateral lung and brain, presenting with motor weakness of the right upper limb and lower limb. And main discussion points, first thing, there's no major improvement even after 7 days. And the motor loss seems to be unexplained by the CECT findings. So though we have referred her to neurology, we didn't get an MRI done while she was admitted for various reasons. Though there was a thought that maybe MRI actually would help us decide why she has this peculiar motor loss, because parietal lobe, nothing is seen in the parietal lobe on the CT, obviously. Frontal lobe is not explaining the motor loss. So yeah, that's it. That's all I have about this case.
Okay. Dr. Vinay, you have any thoughts on this particular case?
Ma'am, she has history of headache also?
No. No history of headache. Just this weakness of the limbs.
They have started acetazolamide.
Given only for 3 days. So I think it was all started.
Did it improve her weakness or something?
So see, after this was on this, when I saw her, it was already 7 days, right? Acetazolamide had already been stopped, and there was only minimal improvement in the right, in the lower limb.
And dexamethasone was continued?
Yes, so dexamethasone is still going on at, I think now 4 mg OD.
4 mg OD.
So that's been tapered off. And I think the last discussion we had, we sort of felt that there's nothing more we can do for her in the, just there.
She has lesion in the chest in upper area?
Hilar region. I'll just show that to you again.
Okay, hilar region.
Right hilar location with right main bronchus is also occluded and it's extending to the left side also. Can you see this?
Are you thinking that it was lower motor lesion or upper motor neuron lesion?
So since there is hypotonia.
Hypotonia means it should be lower motor. But lower motor, then they have acetazolamide. They might be thinking that it is because of because of lesion in the brain. They might be thinking in that direction, but I think it should be in the brachial plexus level.
Okay.
Isn't it? Brachial plexus or
how would it explain if it's brachial plexus, then that doesn't explain
brachial
the
plexus or because lower motor neuron lesion. Otherwise, if
you think spinal
have
cord,
been
no?
from
You mean spinal cord?
Yeah, ma'am, below spinal cord. Otherwise, if it would have been from upper motor region type of, then it should be from brain.
So, right, possibly. So, I think our discussion that time was also that CECT may not pick up everything. Because see, this was head, chest, abdomen, pelvis, all the way to the pelvis, this has been done.
Maybe upper motor, because lymphadenopathy also may be there. in neck region that presses the brachial plexus. That's why they have stopped the acetazolamide, because I don't think there should be it should be from upper brain area. Acetazolamide is given for the reduction of CSF production. That's why they have.
So, yeah, can I please come in?
Yes,
ma'am. Please.
Okay, so so I think we are focused on the area of where palliative care would benefit this patient.
Yes, ma'am.
So otherwise, if we look at brain metastasis from lung cancer, basically the non-small cell carcinomas, they metastasize. It's around 40% of such cancers metastasize to the brain. And sometimes it is a focal area of metastasis, or sometimes it is, the leptomeningeal metastasis. So when it is leptomeningeal metastasis, you do have all kinds of problems, starting from sensory to the motor problems. And of course, the problems of increased ICT and all. But when it is a focal area of metastasis, then, we will need to see, what kind of loss or what kind of manifestations the patient is showing us. So, and that's why the kind of palliative care that should be tailor-made to such patients will have to be appropriate, so that all of the symptoms are taken care of. Okay, so right now, this particular, I think there are certain things that that we might have to do in the long run also. But you haven't mentioned what stage she has been in. Like, has this patient been staged also? See, not really.
I'll just have to check.
So if it is, if it is METS, then of course it is an advanced. But having said this, so what are the, kind of, what to say, what exactly do you see as of now, except for the motor loss?
Except for the motor loss,
she's perfectly fine.
She's perfectly fine.
Her nutrition is balanced?
Yes, she is eating.
Okay.
Only thing, she's not able to move. She's on bed. That is her only concern.
Okay.
Otherwise, she is in good health. She doesn't have any other complaint. And though this CT says that there is metastasis to the lungs, she doesn't have a cough or anything.
Okay. She doesn't have any nausea, vomiting, no seizures,
nothing else.
Anything to do with her blurred vision or something like that?
No. So when questioned, she said this last 20 days she had blurred vision on and off, but while she was admitted, she did not have a single episode of blurred vision.
Okay.
She did have
what about her speech?
Speech is normal.
Speech is also normal. And any kind of, behavioral changes or kind of personality problems she's developed in the times?
No, except for that one thing that they said, that she had forgotten that she had the disease. So from January to now May.
Yes.
So she was diagnosed in January.
Yeah.
But till she had this, this 20 days, this new development, it seems she had totally forgotten that she had anything. So it's possible. I don't know if that was some behavioral issue or because she was not really suffering from anything. She kind of just...
Okay. And how does she react to the, present condition? The loss, she's unable to walk and all. How does she react?
So she's not majorly upset. I think she's a little hopeful now because she saw a slight improvement in her leg.
Okay.
She's thinking that maybe with time, it'll get better.
Okay.
So when I spoke to her, she said कि मैम बस ये हाथ पैर ठीक कर दो, बाकी तो मैं वैसे ठीक हूँ.
Right.
So she seems in good spirits that way, and I mean, since we sent her for that neurology referral because we ourselves are not sure what is causing this. Because if it, the DEXA has also been given for more than 7. It'll be 10 days now. Today started on 4th. So if that was due to this perilesional edema, which I mean, that was also questionable because we didn't find anything in the parietal lobe. If you were thinking that it's because
but
of
then you have actually that CT chest, CT head has shown there is a 3.6 centimeter LED seen in left frontal lobe with mild perilesional edema. Okay. So if there are other lesions also which were undetectable in this particular CT, and those lesions also had some little amount of perilesional edema, because of which they may have contributed. See, everything has to be a little more speculative in this particular case, or else, we might, if we don't presume also, we might lose, giving some benefit to the patient through any kind of medication. But as a preventive measure also, a trial of steroids is a good thing to be done, where you generally have brain metastasis or a primary tumor of the brain also, for that matter, and that is quite justified. And maybe if it is continuing for the last 10 days, I think it's time that we should be tapering it down. And
no, it's already been tapered, ma'am.
Yeah, but then I sincerely didn't understand 4 milligrams of Dexa QID. Why was that done? I mean, because when we have to give dexamethasone, has to be, in a single shot therapy, and that should be tapered in that manner only. So why was that given in divided doses?
I can't answer that, ma'am, because I did not see the patient when it was started.
Okay.
So I only saw her the day I sent the presentation. So 2 days back is when I saw.
Okay, so this was advised by the neurologist?
No, I think the decision was taken in the palliative care unit itself.
Oh, okay.
Yes, because they could not get the neurologist to visit.
Okay, so I wouldn't have suggested actually Dexa 4 mg QID. I would have suggested at least 16 mg, once a day, with proper coverage of, the gastric problems, both local application, local intake of something like mucane gel or, something like that. And along with, twice a day. Yes, twice a day, pantoprazole or at least omeprazole. So I would have done that. And then I would have tapered it down. But then, giving QID Dexa, I don't, there's no evidence actually to give such a medication, like in this manner, Dexa in such a manner. Okay. Sorry. Otherwise, glycerol and I can't comment about Levera or acetazolamide. I think that is that should be advised by the oncologist or the neurologist. But glycerol, yes, that's a good thing that have been added. I think because of the Dexa and the glycerol, the edema might have actually lowered down,
reduced,
and that might have, done some bit of improvement. But having said this, we need to anticipate that the tumors would be growing. Okay, and even if she was referred to neurology for another cycle of WBRT, that would be a palliative intent RT, and until and unless the patient is not in a position or not fit for taking an RT again, because she has already been advised WBRT in January, right? She'd refused that. And there is no previous history of a single shot RT.
No.
Okay, so maybe she is perhaps in a position to take the RT, and that might also work well for her for some period of time. Okay, but having said this, I don't think that I would like to anticipate that the tumors would be growing, and her paralysis might also increase. So at this point in time, Dr. Bijli, I would recommend you to talk it out with, perhaps with the patient and the caregivers or the family members also, regarding what to anticipate, because I feel that by when she told you that हाथ मेरे हाथ पैर ठीक हो जाए इतना आप कर दीजिए, that means she's quite hopeful about coming back to normal once again. And there are instances where patients have memory loss because of a brain metastasis. There are instances, and this is a kind of a manifestation that patients show, along with sensory loss or motor loss, or even nausea, vomiting, and all other things. So I think you will need to talk it out with everybody in the family, and then slowly give some kind of warning shots to the patient herself. Because we will not definitely shatter her hopes, but we will try to bring her down to some kind of realistic hopes where she's able to plan. And it's absolutely your communication skills, which is going to help the patient accept the reality. Okay. And the reality is definitely, going to be a little more worse in the coming days. So, I think I would generally, go with that. As long as, she is not having any problems with her feeding, with her, the sleep, and, other things which matter for example, the activities of daily living, etc. Of course, she is, in a position where she has to be assisted with, bathing and, taking care of herself and all these things. But having said this, these problems are going to increase in magnitude. There might be a time where, she might lose her consciousness also, might go into a semi-comatose state. There might be a time where, the oncologist or maybe the palliative care team itself might think about putting on a Ryle's tube for feeding. So all these things will actually come to the picture. So I think you as a physician and the palliative care team, along with the oncologist, and definitely the family and the patient need to anticipate these things and, you know, prepare for this particular episode or, you know, this reality in future. So I think more of speculating and anticipating things and then keeping your plan B ready for this patient. I would want to, you know, approach this patient in that manner.
Right, ma'am. Yes, I was thinking like now that we have sent her for the neurology referral, then I'm sure a part of her is going to expect something there also. So
yeah,
she will come back to us after that referral
yes,
on an OPD basis. And I guess based on what, I don't know, also what they find, if it is something that can be rectified, I don't know. We will have to probably, I don't know how best to talk to her about.
Absolutely. You will have to talk to her about this because, you know, it's the same thing that she, you know, nobody drops a bomb on her, you know, and she doesn't land up in a situation where she's, because these things come up suddenly, you know, because see, in January when she was detected with that, she didn't have any problem, right? But it was only 20, you know, before 20 days from today that she had this problem, right? And that was also sudden. It didn't start very slowly.
No.
So it had actually come as a shock to her.
Right.
Right. So, you know, we do anticipate that things in cancer base, you know, basically would actually take a serious turn or a serious deterioration, basically in cancer, very, very commonly in cancer. Had it been any other disease like, you know, a end stage renal disease or end stage, you know, liver disease, I wouldn't have expected this. If she was a very frail elderly and it was Parkinsonism or dementia, I wouldn't have anticipated this. But since it is cancer, and you know, as if you remember the curve,
yes,
it's like a plateau and then it dips, right?
Right.
I think she's on that dip as of now, and it's going down even more. So it's better that you talk to her regarding her issues. Try to find out what her insight is about. You know, you'll have to sit with her for a session and then find out what she's thinking about and how she is feeling about. Maybe when she comes back to you next time after the neurology referral, where you know, I would sincerely expect the neurology to say that, you know, don't worry, ye theek ho jayega.
Exactly.
And then, you know, jo ki theek nahi hoga actually, and the whole brunt would be on your shoulders. How you manage the patient emotionally, psychologically, and also, you know, physically. So these things will need to be considered.
Right.
Yeah. And maybe you can also think about, anticipate something about the lung problem, because that's the primary. And it may so happen that, you know, breathlessness starts with this patient, you know. Of course, this is a fact, and the research does say that only 43 or 49% of patients with lung metastasis or lung primary have breathlessness. It is not necessary that 100% will have, but let us count our patient into that 49% also, and then anticipate she might have breathlessness, and then, what to do in that particular area or that particular time. So maybe you can just tailor cut everything and your anticipations and how to deal with those anticipations, how to deal with those situations when they come up, if at all they come up, So I think you have a great plan with you when you do that, and go ahead with that if whenever that situation crops up.
So, Dr. Sangamitra, these sudden jerky movements that she's having, I guess the Levira was started for that. And probably at our end, we will have to continue that, since this will probably not stop, no? We'll probably continue to have, and maybe we'll have to, at some point of time, maybe increase the...
It might increase, or, there might be a hypoactive kind of a state also, where these might stop altogether, because it's absolutely difficult to, pinpoint why this is happening. And, because the manifestations are very, very different. And having said this, we will have to actually prepare for the worst. And let us assume that these movements are not going to stop. They might, increase. Let us assume that. So we need to prepare for that also. We need to prepare the patient and the patient party for that also. Okay. So, I think that's how we'll need to.
Right. Thank you so much, ma'am, because I wasn't sure what to ask the patient to anticipate. Especially.
I remember my, when I was just a trainee in palliative medicine, I remember the first patient that I had was a child of around 13 years. And she was a fourth stage glioblastoma multiforme. And I remember, I was working for this organization called CancerPort in Delhi. And that was my first patient as a, individual doctor, like, leading the whole nursing team and, going for home care. And, I was not really equipped well with a lot of knowledge about GBM and how to handle, the manifestations and what kind of palliative care will work for that particular child. But then I think we managed very well, because the child was comatose at one point of time. And, the jerky movements were also there. There were spastic movements also, the spasticity also of the limbs. There were feeding problems, because of which, the parents had called up one local doctor and put on a Riles tube. And then, all medications were given through that. And then, I had also seen how, the end of life of that particular child. So that was quite a learning point for all of us, since it was very sensitive as that was a child patient, pediatric patient. At the same time, it was a patient who was unconscious for more than 3.5 months on bed. And, the whole family was involved. It was extremely tiring for us, because whenever we used to visit that patient, half of our day would be gone. for a home care. So I think you will also need to prepare for those days, I mean, in the future for this patient.
So I could suggest to her about the home care also, no? While she's here. She's from Bihar, but she's staying with her son and daughter-in-law. So maybe if she stays here, she can...
Yes, why not?
Some home care.
Of course, she'll be, she'll be very comfortable at her own home. And, I mean, as and when required, you can have a look at her. Maybe not doing a lot of active things, but then yes. But having said that, you can always suggest, good physiotherapy for her. And of course, lung physiotherapy, chest physiotherapy that we generally do for our patients with lung metastasis. Nothing, only, perhaps a little bit of steam inhalation or, if
the incentive, no? Incentive spirometer also can be suggested.
Yes, that can also be suggested. I mean, whatever, it should be in her, range of kind of motion exercises for her, and whatever is possible for her for, putting her in a controlled position for herself through breathing exercises. And, you should actually teach her and the caregivers about everything about how to deal with any sort of problem which is because of the lungs, like breathlessness, short of breath, and then, how to do pursed lip breathing and all. What to do if she is feeling breathless, putting her up in a propped up position. So all these things would sincerely help the patient a lot. And of course, the caregivers, the family will not panic because you've told them that these things are bound to happen at one point of time, and they'll be very prepared mentally to face that. Okay. Sorry. So I think that is going to help her, sincerely help her.
Right, ma'am. Yes, I really needed that because when she comes back to us, hopefully next week she'll come back.
Yeah.
Then I should know what to say to her and her daughter-in-law. Yeah. It seems to me like one week they have hopes and the next week I have to bring them down.
It's not bringing them down, but it's like, preparing them for the eventuality. That is one. And secondly, giving them something realistic, which is important because that is the way that they can plan ahead, right? Otherwise, theek ho jayega. Those things I sincerely do not do that with my patients, and you'll have to have a good number of sessions because you will need to find out how much, what kind of hopes she has. She might say कि नहीं बस पैर ठीक हो जाए, हाथ ठीक हो जाए तो मैं अपने गांव जाके I'll do all these things and I'll finish off with my business or whatever, So that may not be possible. And she might be in a very terminal stage, right? So maybe you'll need to, bring her to that real world for now. And you might have to weigh your words, how you say. So those are important, very important.
Challenging.
Of course, yeah. I mean, every day with every patient, we have challenges and they're all different. They're all different. Okay.
Right.
And then, I think otherwise, I didn't see pantoprazole being advised in that particular treatment.
No, Pantop has been prescribed in the discharge slip. Now we have Dexa, which is oral. Pantop has been given, no Mucinex gel. For some reason, Of course, I'm not the primary treating physician here,
Okay.
but for some reason, I observed that in this setup, they don't give Pantop and Mucane gel together.
Why?
I'm not sure. I asked only one resident and she said, you don't give Mucane because then Pantop will not work. So that was very new to me. I thought I'll,
Well,
check
so
this.
pantoprazole is given in the morning. I mean, if you advise once a day, then it is in the morning on an empty stomach.
Right.
And Mucane gel would be, maybe
Twice a day.
yeah, 15 ml twice a day or thrice a day, something like that. And that's quite local. I mean, it's helping the patient locally. It's just like an ointment or an emollient, rubbed on the skin.
Right. So
I didn't sincerely
I really don't know because I've seen this constantly prescribed in oncology. When when patients have these side effects with the chemo and all, they'll give Pantop and Mucane gel.
Yes.
Here, they give only Pantop.
Okay.
So
Well, that's new for me. I will need to find out also.
I'll also need to find out. I need to ask a few more people to know why. I'm sure there is some rationale or some reason why they are not.
Dr. Vinay or Dr. Mahesh, you have anything, any knowledge about this particular thing? Pantop and Mucane gel?
No.
Or not?
I don't think this is actually in all the oral cancer cases, oral ulcer cases. We generally use this PPI with the Mucane gel.
Yeah.
No problem.
Right. So it was
because
new to me also.
Mucane gel is a surface anesthesia. Because
Right.
the patient is having some burning sensation or some difficulty in swallowing, that will be work for only 15-10 minutes or 20 minutes. And pantoprazole has long acting agent which is working on acid peptic disorder.
Absolutely.
So both are different.
And both would be required, no? I mean, they both have different actions. So ideally, both of them should be given, but I'm observing this in this setup and I'm yet to find out. I will ask somebody senior to figure out why they have, why they do it like this here.
The Mucane gel is having lignocaine. Okay.
Yes.
Lignocaine, this is a surface anesthesia.
Anesthetic, right.
Right.
And pantoprazole, they are having this pantoprazole tablet or pantoprazole or some domperidone capsule. They are coated capsules or coated tablets. So they're having some early release particle and some late release particle. So that's totally different.
Right. So they should be given, no? Together.
Yes, definitely. Being a ENT professional, no problem. Don't worry.
The next time I see her, I will include that in her.
Yeah. Okay. I'll just see.
Ma'am, it is said that when they both are given together, if patient take Mucane gel earlier and takes pantoprazole, that it won't be absorbed then.
Oh.
Okay. Maybe the work is the mode of action is interfered or something?
Ma'am, when Mucane gel is taken, then it won't be absorbed. Pantoprazole won't be absorbed.
But then pantoprazole, you're not taking both the
if it is given before meal in the morning, then it is okay.
Yeah, exactly. So that's what my question is.
Sometimes it happens that patient is taking Mucane gel earlier and then taking pantoprazole, then it won't act.
Okay. So I think we will need to, because whenever I have to advise I would advise pantoprazole to be taken early in the morning on anti-stomach, right? And then, whenever the patient is going to have the food or whatever, just before that, mucin. That's how I do. So I haven't seen any case where the acidity or the gastric coverage has not been given, has not occurred because of both these things given together. I've not come across.
Excuse me, ma'am.
Yeah. Sure.
Actually, the mucin gel is a surface anesthetic.
Yes.
Okay.
Yes. Yeah.
We are giving in a small amount, around 10 ml or 15 ml.
Yes. Yes.
And it will from the buccal mucosa to the lower end of the esophagus. I don't think the 50 ml or 10 ml this means high amount. It's a very small amount. So I don't think that it is a very big amount. So and every time surface anesthesia is work for only for 15 minutes or 10 minutes or 20 minutes maximum. So we can give just prior to the meal or whenever patient is suffering from burning sensation or some. So both are totally different. One is before meal and one is just prior to meal.
No, one thing that I know is that antacids would actually they change the pH of the stomach, right? And that is why the acidity is not there. And so many, I think the quinolone group or something, if I remember right, they are not supposed to be given with antacids because of this particular interaction, right? Because they will they will interact, they have a drug interaction, and then they will not be absorbed. Okay. And then I think even I think bisphosphonates also have a drug interaction with antacids, the oral bisphosphonates, but we don't use oral bisphosphonates as of now. And I think, but I don't know about, I'm not aware about PPIs and antacids. Anyway, we'll find out. I think next class we can discuss about this. Okay, so anything else to be discussed today? Because I don't think Dr. Vinay or Dr. Mahesh has any case.
No, ma'am. Today I don't have. Next week I will be.
So Dr. Vinay, what happened to the patient that you were?
Patient is doing well, ma'am.
Excellent. So we're so glad to hear that.
I have one counseling session with her, and she was telling me everything. And yesterday I also talked to her. On Monday or Tuesday, I talked first time in my OPD, and then I talked to yesterday. She was quite happy now. Her pain has also
reduced,
much reduced.
So,
and
kudos to you and your team, and congratulations from our side, Dr. Vinay. This was so nice to hear, sincerely. So glad to hear that she's happy and she's, please go on.
Yesterday she was very happy and also smiling.
Very nice. Lovely. And do you now think that she was having some kind of clinical depression?
Yes, she has, ma'am. She has depression presently.
Yes.
She is out of that depression. She was now out of depression, or to some extent, not fully, but to some extent. Now she was responding quite well.
Yes, very good, very nice. And you have you been continuing with the antipsychotics?
She was continued with citalopram and escitalopram.
Okay.
One drug has been. They have reduced. I think citalopram they have reduced. They have stopped, only with one drug.
Okay.
That has been stopped.
That's very nice. Lovely to hear about.
And she was, for pain, she was taking Dirdol, and her daughter-in-law was also given that massage to her daily. Giving. Now she was quite happy and smiling with me, and looking with smile toward me. Okay. Yesterday, when on Monday we have a long session. I talk about her husband. She has one problem, also another problem. Her elder son is some with a spastic problem or with mentally retarded also.
Okay.
She was also worried about him also. That I came to know about this on that day. That she was asking her daughter-in-law whether they will be looked after her death, about him. How he will do that. She was also worried about that.
Okay.
She was talking about her husband also. And she was from lower socio-economic group.
Okay.
So that's why she was very much worried about her elder son also. But she was now not worried about her disease presently, not complaining much about her disease pain also. And she had somewhat pain also, but she was not complaining that much. Otherwise, she was all the time, she was used to be in sleeping.
Okay. Okay. So if we don't have anything else to discuss.
Dr. Sangamitra, I have a question. Sorry.
Yes, please go ahead.
There was this patient. I mean, I didn't directly see, I mean, she wasn't under me or anything, but I saw the patient. She's a patient of carcinoma breast. She had lymphedema in the right arm, for which she's been given sumac dressing, and she's doing that, and she's been told to elevate the arm. Yeah. But in spite of that, it's been a while. It's still very much there and troublesome. But now she also had a swelling of the left arm.
Oh.
So they sent her for a Doppler, and the Doppler report only says that there is diffuse edema of the left upper arm. I was only wondering, I know this may be a very stupid question. I was wondering, is it possible to differentiate in a Doppler whether that's due to, whether it's a lymphedema or just take out what it is? How do we decide what is it?
See, no. If the left arm is swollen and it is, lymphedema is generally painless, right? If it is because of, sorry?
When it is severe, does it not become painful when the whole arm?
When it is, see, it will be, kind of dragging the limb, right? There will be a kind of dragging sensation of the limb, okay? But there will be no pain as such.
It will not be tender.
It won't be tender. It won't be tender. Okay. But if it is something related to deep vein thrombosis, then of course there'll be pain. There'll be, redness of the limb. There'll be tenderness at one point, perhaps. Have you actually examined the patient?
Yes.
So,
I did. So there is no redness.
There is no redness. Swollen. Okay.
And she says it hurts. It is not tender.
It's not tender. Okay.
No.
It hurts. Okay. The left arm hurts, but the right arm doesn't, is it?
No, right arm also hurts. But now actually, her complaint was actually that they gave her a zoledronic acid injection.
Okay.
About a month back. And she said after that, some 20 days after, 15 days after that injection, she started having this pain. So she is thinking it is because of the injection.
Okay, okay.
But there's no fever. The arm is not tender. It's not warm. I mean, it's not, the temperature is not raised. And there is no redness. And the Doppler does not mention any, in all the blood vessels seem to be okay. So there's no DVT there. But I don't know what else it is. If it was like cellulitis, it should have again been painful, is what I think.
See, it's not like lymphedema will not be painful. Okay, it is generally sometimes, you know, there is a burning sensation. There's an uncomfortable kind of a feeling. You know, little bit what to say. There might be some kind of burning feeling. Okay, generally neuropathic because of the whole swollen arm or the leg. Okay, so that might be perhaps going towards the left side also now, and that is quite possible. That is quite possible. And if the DVT doesn't show anything, I mean, sorry, the doctor doesn't show anything, then definitely, you know, I would say that it might be increasing. But has she been also investigated for any mass in the axillary site, in the left axillary site? Any kind of lymphadenopathy there?
No, I didn't see anybody examined for that.
Okay, any kind of other, you know, any kind of other investigations that have been done for this patient? Any other CT scan of the chest or, you know, ultrasound of the other breast?
No, this was the only advice, and she came in the OPD and she was asked to do this. And she came back and then they, I mean, somebody else was seeing this patient. They advised a sumac dressing again for the other arm.
Okay.
So you think, what else do you think we should, I mean, they should have done, or we should have, or we can do?
I think this would be an early stage, okay, for the means there is evidence that, you know, lymphedema, there might be an impairment of the lymph drainage of the other contralateral side also, okay. There is evidence. So when it is starting, then I think you have to start with compression bandage. Lymphedema, and of course, if she's complaining of pain, then definitely please go for you know, a pain management also with this patient. At the same time, you know, you have to do a lymphedema massage, okay, at least twice or thrice a day. Maybe you know, you can talk with the nursing team who's looking after her, and you know, start with lymphedema massage for the contralateral side also. Okay, so that is definitely you know, going to reduce that. And please take care that no injections and no blood pressure measurement on the affected site, at least. Okay, so I think that should be the first thing that should be done. Compression bandage and you know, the lymphedema massage, because you cannot really have you know, there are no medications that will reduce the lymphedema. It's only the massage. You have to you know, drain the lymph out of that particular arm or the limb, and then get it drained into the system. So, and maybe you know, ask her to elevate her arms so that, you know, there is a kind of a gravitational pull for which this can be.
You can take help of Dr. Vinay.
Okay, Dr. Vinay, yeah, please
Because
advise on this.
sympathetic block can be given and it will relieve some kind of thing.
It is said that stellate ganglion also help
Yes,
in
yes,
that.
yes, yes.
Okay, so next time.
Along with
Satellite
all
ganglion
other
block.
Meyers,
Okay.
stellate ganglion block,
Mm-hmm.
but you have to do all the compression dressing and manual massage also along with it.
Right. Thank you.
Okay, but I'm going to find out more about this particular thing. And I'll definitely let you know in the next class, okay? Because this is quite interesting. I mean, Dr. Bijli comes up with...
So sorry.
No, this is such a great learning experience for all of us. I mean, I have sincerely not seen, I have seen the same ipsilateral kind of a lymphedema, but not on the contralateral side. So sincerely not, I think it may not be rare also. When you've seen, it's quite important that we learn about this also. And basically, the management would be the same. The principles of management would remain the same. Okay, but then we will need to find out how to prevent that from happening. And is it the affected limb is extremely? Is it very swollen? Is it quite like it's sometimes there is lymph seeping out of the pores also? Is
no.
It's not like
That's
that.
not there. And the hand is not affected.
Okay.
On the right side, it is affected, the previous one.
Yeah.
This new one, hand is not affected. It starts from the wrist all the way up.
Okay. So I think, yes, lymphedema massage would really help her. And that has to be very regular. And,
sorry, in this case, now that she has it on both arms, I mean, it will be very difficult for the massage. Which way does it go? And normally you say you take it from the affected limb to the other side. Now both sides are affected. So it just goes to the center. It's not.
So see, when there is room in the hand, it is always advisable that you protect the hand, okay, from getting more affected with the edema. So when the edema is not spreading to the hand part, so let us just try to get that the undrained things drained up to the axilla itself.
Up to the axilla. Okay.
So very superficial light massages all over the skin in a 360-degree manner for the arm and the forearm also, and then coming towards the axilla. Okay, and I think that is, I'm sure that it's going to help her. Because it's when the hand is not affected, I think it's partial as of now, and it can be reversed.
So, sorry, I'm just going to ask one more question.
Yeah, please.
Sorry. So she was advised this sumac dressing for 1 day, followed by just regular bandaging for the next 2 days.
Yes.
So I'm a little confused about the bandage that is done. I'm not sure. Are you supposed to leave it open at night, or are you supposed to give a 24-hour bandage? I'm confused about that.
No, I think 24/7 compression bandage is also not advised. So generally, I would advise my patients to put it on for the daytime, because that is the time when the hand is active. Okay. And that is where, you walk around and you put your hands down so that everything goes down to your limb, right? You just can't walk with your hands up, isn't it? Unless you're resting. So I generally put my patients on a compression bandage on a 12-hour basis at the daytime. Okay. And whenever they're sleeping, I advise them to put their hands above their shoulders and then sleep.
Okay.
So that would also mean that some sort of drainage is also happening at the. But then if you think it logically, the patient would actually sleep. If she's fast asleep, then you just don't have a control on the hands. So you have to give that benefit of movement to the patient and let nature takes its course. But then when it is the active part of the day, then definitely do the massaging and one thing that I have seen, but I do not know whether there is evidence to that or not. Just before going to sleep, if you do one round of lymphedema massage, and then the patient goes to sleep, you find considerable difference after a certain period of time of practicing this particular thing.
Oh, okay.
So maybe you can just do that.
Okay.
So these are all like, whatever I have experienced and something that is very, very practical for us to follow. There are certain things that you will always learn all by yourselves by practicing, isn't it? There are secrets of your practice. So I think, so these are certain experiences that I have had myself with my patients, and I've seen considerable difference, in the lymphedema status. So unless and until it is absolutely irreversible, maybe you can actually bring about a difference and then reverse it for sure. It's a tedious process. It is extremely time consuming also. You have to motivate the patient all the time. अच्छा मेरा ये हाथ फूला हुआ था अब तो ये भी फूल गया है आपको क्या करना है. The patient might slip into some kind of little bit of depression also. She may be irritated. She may be angry on what is happening, and, हर बार सिर्फ उस हाथ को देखते रहना भी, for her, it is a kind of a painful thing. It's an experience that it's something to do with your body image, isn't it? One of the breast is gone and then now the hand is swollen, So these are absolute psychosocial issues also. So maybe, just reassure her कि इतना करने से ये चीज आपका धीरे धीरे चला जाएगा. And when you certainly know that this is reversible, and I'm saying that this is reversible because the other hand is not affected. Okay, we will not let that spread to the hand, like stop it there. Okay, so a lot of motivations, a lot of superficial lymphedema massages, compression bandage also, and then no injections are going to work, no steroids, nothing. They're not going to work. Okay, so it is only by means of manual drainage, facilitating the manual drainage, which is going to show you good amount of effectiveness of these things.
Right. Thank you so much.
Okay. All right. Anything else that we need to discuss? Dr. Mahesh? Dr. Vinay, you want to say something?
Ma'am, will you explain something more about manual massaging?
Okay, manual massaging. See, so when you have a case of lymphedema, okay, yes, generally we encounter lymphedema after a breast surgery. Okay. Yes,
Yes, ma'am.
I mean, whether it is radical mastectomy or partial mastectomy, whatever. I mean, there are certain instances, in surgery, you are a surgeon. So, I mean, Dr. Mahesh is a surgeon, so he must be knowing when you cut all the lymph nodes, there is a problem in the drainage of the lymph. So basically, the lymphedema massages should be started. The exercises basically of the operated part, of the operated side of the breast, the hands, those exercises should be started right on the next day of the operation. I'm telling this to you because I have had this personal experience. My mother had a left-sided breast surgery because of, say, breast stage 2, and I had taken her to Tata Medical Center in Bombay, and I have seen right from day 2 of the operation, of this major operation, the physiotherapists have started, all the exercises to prevent lymphedema from happening. And those were quite painful at that point of time. It was painful because of the surgery that she had undergone. But, whatever was possible at that point of time from day 2, it has prevented any kind of lymphedema from occurring. And my mom is right now, she's a survivor. And, there is no problem in her hand, on the left hand. So we take like 100% precautions by not examining the BP, by not giving any kind of IV injections or any IM injections, protecting the hands from getting the skin from getting exposed to any kind of mosquito bites or insect bites. Has been wearing, the full sleeve blouses since then. Since she had her operation in 2013. So since then she has been quite careful about this. And I have been like, sitting on her head by always trying to say that. So these are the preventive measures that you can do just after the breast surgery. But when we see that for some reason, even when you take precautions also, there are instances where the limb starts, the lymph is not drained properly, and there is, visible swelling on those areas of, it starts from the axillary part only. It doesn't really start from the lower part. The periphery, it doesn't start from there. So when you see that, you have to start proactive lymphedema massages. And lymphedema massages are very superficial massages done with both your fingers, and you are actually trying to drain the superficial lymph from the subcutaneous tissue towards the axilla, where there are larger lymph vessels, and you're trying to push that stagnant lymph, if I may say so, towards the larger vessels that are lodged in the axilla and other part of the chest. So that is a proper lymphedema massage, and you should do a proper lymphedema massage by very superficial movement of both your index finger and the middle finger. You may also take the ring finger, also a 3-finger type of massages, and be careful of not actually giving very kind of more pressure into the hand, like as we do in the Thai wala massage, if I can say so. So not that one, but very superficial, very gentle massages by taking the limb up on, resting the limb up on a kind of a pillow maybe, and at the level of the shoulder, so that maybe a little higher also, so that the lymph that you drain towards the axilla actually is facilitated to get drained into the larger vessels lodged there, and that goes into the circulation. So that is a preventive kind of a thing. But then when, it's always advisable to wear compression stockings, so that, there is the lodgement of the lymph doesn't occur on the peripheries. So compression stockings would work on that manner, and your massages should work on that manner. So both of these things, got together, and they act by preventing this to happen. So this is about like the lymphedema. Was that all right, Dr. Vinay?
Yes, ma'am. Thank you, ma'am.
Oh, okay. You have breast cancer patients coming to you?
Yeah, ma'am.
Okay. So have you encountered any kind of lymphedema cases?
Yes, ma'am. Many patients, but our sisters are giving, they are advising how they should do it.
Yeah. Of course. That's a proper nursing advice, actually.
They are teaching compression bandaging and also about the massaging.
Yeah. Many patients may not be able to, afford in our kind of settings, like government setups, they're not able to afford compression stockings, where we advise them to put on the crepe bandage. The crepe bandage can also, the crepe bandage, right?
Yeah.
Mm-hmm.
Yeah. So that can also be, at least kuch to unko fayda hoga usse. So the crepe bandage can also be put on, and this can be prevented from happening.
Thank you, ma'am.
Okay, thank you so much. Anything else?
Thank you, Dr. Sanghamitra.
Yeah. Anything else we need to?
Next week, what should we prepare, ma'am? What should I
next
prepare for next week?
No, whatever case you have. I mean, anything interesting, any new topic that today, I mean, we discussed about brain metastasis and the difficult part of how to bring the patient to a realistic level. And of course, the lymphedema part. Those are new things that, we feel that these are very small topics, but they help in managing your patient a lot. And the massage part, as I told you, Dr. Vinay, you have seen the difference in your patient, because the daughter-in-law has started to massage her, your patient, and that has brought some kind of smile to her, right? She was smiling at you. So I think that's a great reward that you have got. And, the touch therapy is sincerely extremely rewarding. And henceforth, lymphedema massage by a nurse, a trained nurse, brings in a lot of comfort to that particular patient. And there are instances where I have seen that even if the lymphedema massage is going on, the compression bandage is also on, still for some reason, the edema keeps on increasing. But the therapy that goes on makes the patient, satisfied and smile कि हाँ नहीं मुझे कुछ तो कर रहे हैं ये लोग, ऐसा तो नहीं है कि मुझे छोड़ दिया है, right? So those emotional connotations are also very important for our patients and us too, because our satisfaction is also one factor that keeps us motivated to work for them, right? So I think that's about. Anything else? But I'll definitely look into the contralateral thing and the PPI and the antecedents, and we'll
I'll also check. Theory on that.
So, okay, so I think we have. It's already 8:20, and we can wind up for today. Right. Who's there? Rajlakshmi, are you there?
Yes, ma'am. Yes. I think we can wind up for today.
Yes, we can wind up. If I can request